So I think as orthopedic surgeons, as young, and in the case of Worm, not so young orthopedic surgeons, we want to dive into the technicalities and the intricacies of whatever topic it is we're looking at. So I want to try and take a step back and just give us a framework, almost in a back to basics kind of way, into which we can fill those gaps with the technicalities that will come later on in this in the talk. So if you go right back to the start, even the definition of knee dislocation being tibiofemoral disruption or some variation of that is fairly simplistic but flawed. You're going to have a patient, a not insignificant number of patients coming in with that X-ray from a spontaneous reduction. So now you're dealing with a bit of a conundrum. Is this a multiligament knee injury that has spontaneously reduced, or is this a non-dislocated multiligament knee injury? And I use the two terms as separate entities. I think we do.
I didn't realize there was going to be load shedding today.
We do sometimes use them interchangeably, but just be aware that there are authors who would suggest against that. There's an implication from a knee dislocation, which is obviously the neurovascular compromise, that's not necessarily as highly associated with a non-dislocated multiligament knee injury. And then in addition to that, knee dislocations fall on a spectrum. So from, not all knee dislocations are the same and should not be treated equally. So how do we work our way through that? We'll go through three of the classification systems. The energy transfer, seems fairly straightforward, high and low. The high does fairly poorly. That's your high-speed MVAs, your falls from a height, your crushing injuries, and they don't do well, as opposed to your low-energy injuries. The typical sportsman, they're going to do a little bit better. But the unique entity I want to talk about here is the ultra-low. This is really essentially or exclusively a disease of obesity, with average BMIs approaching 50 in the studies that I looked at. The reason that I want to bring it up is because while you look at these patients, you take the history, and the history that they give is rather innocuous. It's often just during an activity of daily living. But if you look at the vascular and neurological complications, it's equal to all pooled knee dislocations when you compare them. So you really have to, although it's an innocuous sounding injury, you have to take it seriously. The Kennedy positional classification doesn't hold much value when it comes to communication or decision making, so we'll skip over that one. Really leaving the Schenk classification, which is the majority or the most widely used classification system. From the beginning, the fairly rare, but exists in reports, single cruciate intact knee dislocation, to what some people call the true knee dislocation, being the bicruciate, and on to involve the collaterals. This has been modified to include vascular and neurological damage, and Prof, together with Professor Schenk himself, is looking at trying to modify this to include open injuries as well. So in my second slide, I put up this X-ray as the spontaneously reduced knee dislocation, and said that it's important to try and identify whether this is a spontaneously reduced knee dislocation or just a multi-ligament knee injury that was never dislocated. Now, it can be really tricky, besides for an obvious history of a dislocation that's spontaneously reduced. In the absence of that, it can be difficult. And there's two little clues that I'm going to try or that I came across that I thought were quite helpful. And that is these subtle little innocuous looking fractures that you'll see around the knee. So in this case, that innocuous looking anterior tibial plateau rim fracture, almost like a rim avulsion. It looks minor here, but it's a sign of something far more sinister. This was caused by the femoral condyle riding over the anterior tibia and avulsing that. So in a posterior knee dislocation, this specific patient was missed and ended up having an above knee amputation. So don't let that be you. On the flip side of the knee, you've got essentially the mirror image of that is this excessively deep lateral condylus sulcus on the femur. What's happened here is the posterior tibial plateau has caused an impression fracture on that femur as it's gone over the front, so an anterior knee dislocation. Still difficult though, and can be a challenge to figure those out. These are, on the whole, devastating injuries, all knee dislocations. One of the reasons is the obvious vascular insult that we all are very aware of. So, I mean, it's a fairly useless point, because you're going to look hard for vascular injuries in all of them, but highly associated are your KD3L, that's your both cruciates and your lateral side torn, and the posterior knee dislocation. Those have the highest rates of vascular injury, together with neurologically damaged knee, so a common peroneal nerve damage. Those should be red flags to look even harder than you would normally do, because of the obvious risk. So a missed knee dislocation, a missed vascular compromise can lead to an 80% amputation rate if you get it wrong. So we try and prevent that with early detection. And if you're working through C14 at Groote, you're probably going to have a CT angio done on these patients as sort of a knee jerk by the casualty officers. I'm not saying it's a bad thing, but just be aware that serial ankle brachial index and selective angiography, so if you use those as buzzwords, serial ABI and selective angiography is probably the gold standard. But you have to know how to do it properly. So if you're going to be doing ABI, it's not just a blood pressure taken on the arm and a blood pressure taken on the limb. You need to use, number one, the appropriately sized blood pressure cuff. You've got to take the highest systolic of both limbs using a Doppler ultrasound, getting the systolic pressure. And then in the leg, you look at the dorsalis pedis and the posterior tibial artery, take the highest of those two, and that's your ratio. If you do this properly and serially, then it's a very accurate way of detecting vascular damage. So it has a positive and negative predictive value approaching 100% in a number of studies. Neurological complications, I think, it also seems fairly basic. 25% of knee dislocations are going to have an associated common peroneal nerve palsy. Of that, 25% will recover function. So nice, easy statistics that you can hold on to and tell your patients. It's obvious that lateral-sided injuries are going to be associated more highly associated with nerve complications. But something that I want to dwell on here is the implication of this drop foot specifically on your knee. So if you have a patient who has a drop foot, in order to try and achieve heel strike during the stance phase of gait, what they're going to do is they're going to try and hyperextend their knee as a compensatory mechanism. So if you have grafts inside a knee that are, you want to try and protect as much as possible, this hyperextension is going to place a lot of undue strain on these grafts. So think about addressing this foot drop earlier rather than later, be it with an ankle foot orthosis or some form of tendon transfer. The next topic is, where does stress radiography fit in? I think as juniors, we tend to feel that MRI is the panacea, the be-all and end-all of imaging in knee dislocations. But while, if available, it should be done as a routine, it does have its limitations, and it's important to know where those limitations lie. The three examples that I want to give here are in your suspected incomplete ligament ruptures. So your MRI will show the signal change, incomplete ligament rupture, whereas a stress radiograph is really going to give you some functional information. Is this side incompetent? Does this need to be addressed surgically? Almost more importantly, in chronic injuries, so patients who come to you either referred late or only presenting late, or you're doing delayed surgery and you need some more preoperative information. If you've had a ligament rupture, specifically extraarticular ligaments, if you've had a ligament rupture that's then healed in an elongated fashion, the MRI is going to underestimate this incompetence of this ligament. It may show up fairly normal, but a comparative, side-to-side stress radiograph is going to demonstrate this incompetence well. And then in follow-up to see if you are, you for academic purposes, to see if your grafts are still holding in there. And then you can convert those radiographic measurements to a grading of injury in these tables. I don't carry this with me, but it's easy to access when you need to just refer to it. With regards to the management of these patients, I think, these can be complex injuries. These can be polytraumatized patients. You have to remember that you need to apply an ATLS principles to the management of them from the start. But with regards to the knee itself, Prof's put together this pyramid, and I just want to take you through it. So starting off from the bottom there, have an awareness of the artery. I think we do, but remember about the soft tissue. Have a lot of respect for it. Let it settle, watch it. Bones, so deal with any long bone fractures, adjacent long bone fractures. Deal with that before you deal with the knee. Really, the ligament repairs and reconstructions is the tip of the pyramid. And if you are getting there, you should be asking yourself, where am I? What is this? Is my setting, is my hospital ready for this? Am I ready for this? Do I have the surgical skills available? Because remember, as opposed to an all arthroscopic complex ligament reconstruction, there are other options. There's open surgery that's an option. There's no surgery that's an option, both of which are better than, as it's been aptly said, an arthroscopic cock-up. So think about it and just have sort of a prudent approach to these patients. But if you are going to be addressing them surgically, a few general principles I want to deal with before we get late into the specifics a little bit later. So a quote, long-term outcomes after external fixation are worse in knee dislocations than in patients who did not have an external fixation. Now, I think there's a lot of confounders in that statement, in the sense that the worst dislocations, the worst injuries are probably going to be the ones that were X-fixed. But regardless, patients don't do as well if they've had an X-fix on than if they don't. So if you can avoid it, do. But there are certain indications where an X-fix is necessary. And those are quite specific and well documented. But in your open injuries, as in the picture that I've given here, vascular repairs with grafts that need to be protected, in a residually subluxed knee after your reduction, and in a big leg that you just can't hold with a pop. And then if you are going to be putting on an external fixator, think about the pins. You have a second stage of an operation coming up where you need to have a lot of femoral tunnels drilled, tibial tunnels drilled. Think about where your X-fix pins go. Get them high, get them out of the way of the zone of injury and the zone of your second operation. Do you need to operate at all? Well, it's widely accepted in the literature that surgical management is now superior to conservative in the right hands. These patients do better. They have faster return to work, improved knee scores, less instability, less stiffness. However, these are in the right hands. So if you're in a resource limited setting, and the right hands might not be your hands, it might be your setting, your hospital's, figuratively speaking, the hospital setting, the physiotherapy, the rehab, access to graft, etc. Perhaps non-surgical management is going to be better for that patient. So you can achieve acceptable outcomes, but you have to do it specifically. And this is a very brief rundown. You can get much more detailed in how to do it, but just the basics. Get your closed reduction, it goes without saying. But then make sure that it stays reduced. So while you're immobilizing this patient by whatever means necessary, that could be an X-fix or a pop, whatever you have to do, make sure that you keep imaging them and that you're not just immobilizing a subluxed knee. Patient must be non-weight bearing. And then after that, you can anticipate that they're going to be quite stiff. So rehabilitate them, and they may require minor surgical procedures at a later stage to try and get some range back. But enough about that. We want to talk about operating. So if you're going to operate, are you going to repair or are you going to reconstruct? So repair, obviously it carries a lot of benefits or perceived benefits over reconstruction, in the sense that it's probably a bit of an easier operation. It's smaller incisions, less graft harvesting. You're saving that autograft for your reconstructions that you have to do at a later stage. The patient's going to have less post-operative morbidity. But there are limitations to what repair can achieve. So those limitations are, from the beginning, it has to be done early. So ideally in that acute window, less than 3 weeks. It's not a hard and fast rule, but you should be aiming for early with a repair. And then also, what can you repair? The lateral side, specifically the LCL and the posterolateral corner, tend to do worse with repair, with a 40% reoperation rate, as opposed to a 6% reoperation rate if they were reconstructed. While the MCL and the posterior cruciate have good healing potential, so those could be addressed with a repair. And internal bracing, as shown in the picture here with a fiber tape, is renewing interest in these techniques. So the age-old debate of timing of surgery, well, the debate rages on. And I think to give yourself an understanding of the debate, don't try and remember the issue. Remember the concepts, have an understanding of what those are, and you'll be able to apply that to your patient and your setting at a later stage, and make better decisions, as opposed to just parrot learning, early or staged or late. So the concepts that I think should be understood is that not everything that is broken needs to be fixed. So specifically here, I'm referring to, for example, an MCL rupture or a partial PCL rupture that you're going to see in the acute phase. These, if you leave them appropriately immobilized, they have a good chance of getting better on their own. And then once those have healed, you get your range back and you address everything else that needs to be addressed. So significantly less operating. However, the flip side of that is not true. Once you operate, you need to rehabilitate. Repairs, as we've said earlier, must be done early. So ideally in that 3-week period. Otherwise, you're sort of heading towards reconstructions being necessary. Damaged capsule leads to fluid leakage, and fluid leakage leads to potentially compartment syndrome. So obviously a bad outcome. And inflammation is bad. So you've got the first insult of the knee dislocation, the second insult being your 3-hour-long knee operation, and the end result could be arthropfibrosis and a stiff knee with a poor outcome. On the flip side of that, though, leaving a knee to try and get it to settle, while you're leaving it to settle, you've got abnormal biomechanics. And that abnormal biomechanics is leading to ongoing cartilage and meniscal damage. So now apply those principles to the three options you have. Number one being early, or within that 3-week period. So here you're getting earlier, you're achieving normal biomechanics earlier. You have the option of repairing the ligaments that can be repaired, but you have to address all of them that are damaged, and you risk arthropfibrosis. So those are the downsides, as opposed to staged. Here you could do the collaterals, for example, in the beginning, give yourself the opportunity to do a repair as opposed to a reconstruction, and then later on come back and fight another day with the cruciates. Then a delayed option. So this is where you allow the ligaments that are going to heal, give them time to heal, appropriately immobilized, and then come back and get your range of motion, and then you only need to address the ligaments that remain. The problem here is that cartilage and meniscal wear continues while those abnormal biomechanics exist. So this is a sort of summary from a number of articles. The trend internationally in these resource-rich environments is to early surgery. But in a resource-limited setting like ours, with theatre constraints, limited access to physio, perhaps a delayed approach is the prudent option. So I've definitely overstayed my welcome here, but just a few points that I'd like to highlight. I know it's gone quite quickly. So look for that spontaneously reduced knee dislocation and understand the importance of that. Don't underestimate the innocuous sounding history of the ultra low energy knee dislocation. Understand ABI and selective angiography is probably gold standard, but you have to do it properly. And if you can't, then CT angio is a better idea. Stress X-rays add value, so know when to use them. Be realistic about what you can achieve in your setting. If you try and avoid X-fixes, if you are going to use them, then be careful where you put the pins. Think about your second operation. The MCL and PCL heal well, while the ACL and PLC or lateral side do not. And perhaps in our setting, a delayed approach might be the prudent option. Thanks very much.
John, thank you very much. Very nice presentation. Put a lot of work into it. Thank you very much.
Thanks, Prof.
I also like your points, your takeaway points at the end. It's always nice to have that, just to kind of in a complex topic, just to kind of get back to. Is there any questions? Anyone wants comments? Now's your time. So I think what I'll do is I'll just highlight 2 or 3 things that stand out in that talk that I think we must just remember for practice and for exams. The one is a general approach to a knee dislocation, and the main thing is really to have a priority or prioritized injuries that you exclude, and mainly starts with the perfusion, and it goes to the soft tissue integument, make sure that there's no wounds around. And then fractures, the care of fractures is obviously the long bone fractures, but also if there are avulsion fractures around the knee, that changes your management, because you tend to do repairs in those patients more than reconstructions, because bone heals better to bone. And then only once you've done those assessments, then you focus on the knee and on the ligaments, and you really try to understand what the injuries are and what the instability would be for that patient in the future. Now, once you've done that, then you need to figure out where you are. If you're in the secondary level hospitals, you don't have accessible knee surgery for whatever reason, you have to make a plan for that patient, that and you can't just use what the gold standard is in Europe or in the States. You have to kind of adjust to what you've got. It's completely acceptable to treat a patient conservatively if you don't have the means for surgery, if you don't have surgical time. It's also completely acceptable to treat patients in a stage fashion. For example, you manage to repair ligaments, and say you do the collateral ligaments, and you put the patient into a plaster or into a brace for a certain period of time, and then figure out if the other ligaments need to be addressed in the future or not. It can also mean that you delay things, and you say, look, tell the patient to come back in 3 months, 6 to 3 months, once you've confirmed that the reduction is adequate, and decide with the patient what ligaments is giving him the trouble. A lot of it will be the resources that you have in your hospital. So you might not have allograft. You might have to be able to harvest various autografts, and not just the hamstrings in that leg or around the lower limbs. And that all affects how you manage the patient. So it's a tailor-made approach that is not what we teach you now is the gold standard for everybody's hospital. And I think just for the MOs, if there are any MOs around, and also for the trauma registrars treating these initially, an X-fix of the knee really during a knee or after knee dislocation really has very, very specific indication. We shouldn't just put an X-fix on, if we don't know exactly why. And there's really those 4 indications that John mentions: an open injury, vascular repair, residual subluxation. If you can't reduce it properly, and there's some subluxation, you're worried that the patient will basically become stiff or subluxed in that position. It's very difficult to treat it in the long run. And if you can't brace the leg, Wherever you go, you're always welcome to show me an X-ray or involve me in your decision making. So, are there any questions now? Still not. You guys are so quiet. I must actually then ask questions myself. Let me ask you this question. Let's go to the guys writing. Dalroy, I'm just going to ask you a question. I don't want to embarrass you. So what's your favorite ligament in the knee?
Probably ACL, because it's the one I could possibly fix.
Really, ACL. I was going to go with that, your favorite ligament now, but the ACL is really not really my favorite ligament. Okay, besides the ACL.
It's too easy for you, Prof. That's why.
So do you guys want to go through the ACL first? Let me share my screen. So do you want to do the ACL first?
No, it doesn't matter. Whatever you had planned.
My favorite ligament is the MCL. I'll go with that. I shouldn't have asked you. Sorry. Can you see that?
Yeah.
Okay. And I'll do the ACL next. So what I would do now is basically, you've had an overview now, and now we'll just go into the various ligaments that can be torn and try to figure out, number one, what the anatomy is, because that really helps you to direct your treatment and to understand the biomechanics around it. Is this now the PCL? What have I got now? What am I sharing here? Sorry. I've got too many screens open.
Hi, Prof. Can I just quickly ask something?
Yeah.
Just on the general principles that Virgil was talking about, just touching on chronic, like multi-ligamentous knee injuries, like a missed one, for example. Now a patient comes in with like various deformity, for example, with like a PLC injury. What's your like philosophy on like corrective osteotomies and timing when it comes to further reconstruction of the ligaments when it comes to that surgical approach to those type of...
Someone is a good question, and I'm going to touch on that when we get there. But you've hit a very good point there. The one thing is, what do I do if I can't manage this knee dislocation or multi-ligament knee injury now? What if this patient comes back with a chronic instability? And oftentimes, when you don't address the patient initially, or the knee dislocation or instability initially, it starts to become more complex. For example, you could repair ligaments now, an MCL, and in the future, you might have to reconstruct it. Or let's say you have to reconstruct the MCL and the chronic MCL injury in the future, and all of a sudden you realize that there's a valgus knee and your reconstruction will actually fail. Now you have to change the axis. Whereas when it's an acute injury and you have various valgus deformities, you tend to disregard them initially, because you're basically hoping that your first repair or reconstruction will basically overcome those initial issues. But once there is a deformity in the knee and a ligament laxity, it just starts to become a vicious cycle. But we'll get to that somehow. It's a good point. So let's talk about the MCL, and the reason why is that I've completely misjudged this ligament, and also many people have really neglected this ligament because it heals well, and it's a nice broad extraarticular ligament that we don't really tend to think about too much. But there's recently been quite a lot of discovery around the components of it and what those components are doing and how they work together. And so that's why I want to just show you. So the main concepts around the anatomy actually also affect a lot of the other aspects around the management of the MCL. It's basically got these three main components that we talk about. That's the superficial MCL, and I'll get to all of these components a bit later on. This is basically the middle of the knee, or in the middle of the equator of the knee on the medial side. Then you've got the posterior oblique ligament, or the posterior medial structures of the knee, which is basically here in the back. And then you've got the deep MCL, which is not seen here, and I'll show you later on where it lies. The main thing is that what you can see here is, because it's so broad, it doesn't actually have isometry. And so if you take any of these points, really only if you stay in the middle of that, basically this pin here, would you have a perfect isometric ligament. And that's why if you put an anchor to repair the ligament here in the back, and you fix a part of the ligament that's actually torn here, you create isometric forces around the ligament. And it's the same for something that is torn in the back and you fix it to the front. So the tunnel placement or anchor placement, if you want to reconstruct them or repair them, is quite important. But overall, we know it heals well. The problem is, if it heals, does it heal elongated? And ideally, it would be nice to predict which ligaments, which tears of the MCL would heal elongated or not, so that we can address them before that time. So on the tibia, the tibial attachment sites, the deep MCL is a ligament that's an oblique ligament, which I'll show you just now, which it inserts very much almost at the top of the tibial plateau. This is even too distal. It's literally 5 millimeters from the rim, and it's underneath the superficial MCL attachment sites. So the superficial MCL actually has two attachment sites. One is proximal, about 12 millimeters from the joint line, and the other one is distal, about 60 millimeters. And it's literally just under the pars that runs over it. That's important to understand during ligament reconstruction. It's also nice to understand for total knee replacement surgery and when you need to release stuff there. And then on the femoral side, you've got all these, and don't remember them, but just be aware of them. I also always just print it out and put this page next to my theater table, or I look at it before I do the surgery, because it's quite difficult to see all these things in your head when you do surgery, especially when the knee is flexed or extended. Those attachment sites change quite a bit. The main thing is really the adductor tubercle, which is this point here, which stays constant. Oftentimes the medial epicondyle is torn off or is quite flat, so you can't really feel it nicely. So the best way is actually to really look for this adductor tubercle. You can find a tendon that attaches to it, and then along it, basically orientate yourself until you reach the insertion site. And then from there, you can kind of orientate yourself where all these points are. The superficial MCL is attached a little bit proximal and posterior to the epicondyle. Like we said, the deep MCL is just distal to it, and the POL has actually got this broad attachment site on the femur, and that shows you it basically, the reason for it is that in extension it becomes tight, in inflection it becomes loose. So with the posterior part of the attachment sites, inflection moving anterior, it becomes less taut. I wouldn't also try to remember all the anatomy of the posterior oblique ligament, but what is nice to always kind of keep in mind is that there's static and dynamic stabilizers, and the dynamic stabilizers are usually the hamstring and the hamstring complex. So not just the semimembranosus, but also the semitendinosus and the gracilis. Because let's say an ACL, MCL injury, now you want to harvest your graft, and if you take the hamstrings away that are dynamic stabilizers of the medial knee, you're actually taking away quite a bit of stability of the knee. But the static stabilizers is usually what we talk about when we try to reconstruct ligaments. people talk about these various layers, and I think this is such a nice way to think of them in a simplified way. Basically, once you cut through the skin, you hit this layer of fascia, and then you hit anywhere in the front, anterior, middle, and posterior part of the middle side of the knee. Once you get further down, there's nothing anterior. You basically hit anterior to the midline. So we're talking about right here. There's nothing here in the front, but on the middle, around the middle of the second layer, you find the superficial MCL, and underneath it you find the deep MCL. So that's basically what this is trying to tell you: is anterior, you don't have anything in the second layer. Then in the second layer, you come in the middle, you come to the superficial MCL, and posteriorly in the middle layer, you come to the posterior middle corner, or the POL, posterior oblique ligament, which is this structure here. And then once you cut that away, you come to the deep MCL. And posteriorly, you basically hit the capsule. So we've chatted about this, the chains of length. It becomes quite important in terms of tensioning when you put an anchor into the back of the, to reef up the posterior capsule of the knee, and you reef it up. And remember, this is like one of the most valuable information slides for someone that is just starting off to treat these injuries surgically, because an MCL repair is not really something that's too challenging in terms of the approach, but it is challenging to find these points. So once you put your anchor here and you reef up the ligament, put sutures in it, you actually don't want to tighten the ligament in flexion, because you're going to over tighten the capsule, and you're going to the knee is going to become very tight in extension. So you want to tighten the capsule in flexion and realize in extension, and realize when the knee flexes up that you'll have a loose capsule there, and you're thinking, my ligament repair has failed already, even during surgery. But you must realize that it's a sock that tightens in extension, and it needs to be sutured and repaired in extension. That was the POL, the posterior oblique ligament. Here again, you see it is loose in flexion, and it tightens in extension and in internal rotation. Now, because the ligament is so broad, look at this ligament, look at all the attachment sites. This ligament is so broad that it doesn't only prevent or give valgus instability, but also gives you rotational instability. But the main thing, and this is what was really difficult for me to understand, it acts against internal rotation if certain parts of the ligament are torn, and it acts against external rotation. So it tightens in external rotation and it tightens internal rotation depending on which part you look at. So looking at the posterior medial corner and the posterior oblique ligament, which comes basically from the semimembranosus tendon, and it inserts and goes into the MCL, you see that it tightens in internal rotation. That means if it's torn, you'll basically have, when you internal rotate, the tibia will come forward. So, and this is now the deep MCL. The deep MCL is basically this, I want to show you here, it almost looks like a ligament that is basically right next to the femoral condyle and under the superficial MCL. And it's got the same orientation as the ACL. So what it actually does, because its fibers are obliquely orientated, is that it tightens in external rotation, and it also prevents anterior translation. So this ligament here has a different function than the superficial MCL. So this is quite intricate surgery, anatomy, which leads to intricate surgery if you really want to do it well, or if you really understand. And when I started off, and still to this day, there are some cases where after my surgery, I see this patient 3 or 6 months later, and the patient is stiff, but unfortunately, he's got valgus instability. That means that I've misplaced the tunnels or misplaced the anchors on that ligament. And I've created an unisometric ligament that gives you valgus instability and it prevents your flexion. So it also now you need to understand where, and what type of, where this ligament is torn. By the way, this is not something you need to remember, but there is X-ray orientation that can be really helpful if you just get lost in your anatomy. Put that printed out, put it next to your table, and you'll be able to, with the Shetler's point as an orientation or beacon, you'll be able to navigate yourself around the knee as long as the knee is perfectly aligned on a lateral X-ray. And it really helps you to kind of see which ligament you want to at the moment want to address. So besides the MCL, there's also usually other ligaments that are torn or menisci or cartilage damage that has happened in the knee. And that's why it's quite important to do a good clinical exam. And starting obviously with the history, you need to understand, was the rotational problem, rotational force on the knee, or just a pure valgus force? Sometimes very difficult for the people to really tell you. But what really helps is the contact or non-contact injury. Usually in the contact injuries, more than one ligament goes. And you have a look at the skin, check for open wounds, and obviously check for the pulses. This sign is called the pucker sign, which basically you're looking at the condyle, you're looking at the femoral condyle that's buttonholed through the capsule on the medial side. And oftentimes the MCL is basically folded into the joint. This is not something you can reduce in the front room. This needs an open reduction. It's just nice to keep in mind when you see these patients in the front room. Now, we're going to go to the various testing now, but this is just an interesting way to test for rotational instability in a knee that's flexed 90 degrees. You basically apply force to the knee by external rotation and anterior translation. And now we know when we do that, if the anterior medial tibial plateau comes forward in external rotation, then most likely the deep MCL is affected. If you internal rotate the knee and the tibial plateau moves posterior with an intact lateral collateral ligament, so the hinge is lateral and you move the tibia backwards and it hinges around the lateral side and the tibial plateau moves backwards, then the POL, the posterior oblique ligament, is torn. So it is not easy to really objectively analyze this in a clinical setting or in your rooms or in your clinic, but it's something you have to keep in mind when you do surgery. These dial tests are nice, but you can never really see the tibia. So you can see that there's more external or internal rotation compared to the other leg, but it doesn't really help you to really understand where the tibia moves during your examination. And so similar to the PCL that you've seen with John's talk, there's also stress use you can do here, and you can compare them to the other side. What it really comes down to is that if it's more than just over 3 millimeter opening, side to side difference, so you take pictures or x-rays of both legs, and then if there is a 3 millimeter difference between the gaps of the medial and lateral of the right and left leg, right and left knee, then you know you've got a grade 3 superficial MCL injury. If that opens up a lot more, if it opens up more than 10 millimeters, then you know the cruciate ligaments are also gone. So this is basically another a very nice kind of way to assess an MCL injury, especially if you don't have an MRI scan. On an MRI scan, you can look at a lot of things and you can correlate what you found in your clinical exam. In your clinical exam, you really want to try to see, where is it painful? On the epicondyle, is it painful around where the meniscus is? Is it painful proximally? Or is it maybe even painful in a distal insertion? And it really helps you, and you can pinpoint where this ligament is torn. And on an MRI scan, you can correlate that. The MRI scan also shows you lateral bone bruising and kind of differentiates that from meniscal tears on the lateral side. It shows you whether there is a bony avulsion that you might not have noticed on X-ray. And it can help you to plan your surgery, especially if your incision making makes a big difference to know exactly where the ligament is torn and whether it's intact. If you want to treat this patient conservatively and you have you really trying to keep these patients out of your operating room, you must make sure that the ligament is not folded over the pes. This is the pes. So this is these are the medial hamstring tendons. The ligament is torn off the bone, it's pulled up and it's folded over the pes. It will never heal onto the bone. So this will result in chronic instability. And it's something nice to see. You see, this ligament is very wavy and it's overlying the pes. And you have to click through the slides to really see it properly. It helps you, like we said, to really understand the level. Something that is proximally heals better. Something that is torn on the mid-substance, you might need to actually augment when you repair it with a graft. And something that tears off from the distal part of the insertion, on the tibial insertion sites, might really struggle. You might really struggle to have it healed. So you might actually want to actually repair this ligament earlier than later compared to the femoral tears. This tendon lesion we've chatted about. Now, when we do arthroscopy, so you can see that the knee opens up a lot more than in a healthy knee with no MCL instability. And you can use the probe to kind of gauge if it's more than 10 millimeters that you have a drive-through sign with a scope that is 7 millimeters thick, then you know that the MCL is most likely torn. But you can also see the deep MCL. I wanted to show you this. So the meniscus is attached to the MCL here, and you see that the deep MCL, depending on whether it's torn, whether the meniscofemoral or meniscotibial fibers are torn, the meniscus will float either way. So if the meniscotibial fibers are torn, the meniscus will float proximally, and if the meniscofemoral fibers are torn, then you'll find the meniscus on the tibia, and you'll find a gap proximal to the meniscus. And this really helps you also to guide your management. So I want to show you a couple of cases. So we all want to treat meniscus tears conservatively, but there's a few things that we want to a few exceptions. This is a kiteboard injury, a person that is a professional kiter, and he visited us at Christian Barnard Hospital, and he was worried that he might need surgery. So what do you guys think? Delroy, what would you do?
Prof, I'm looking at a coronal MRI on the left and stress views of X-rays on the right. With regards to the MRI, it's a T2 weighted image, and it looks like there's an MCL injury originating from the femoral side. There's increased hyperintense signal around the proximal or femoral attachment, and there's increased signal around the medial meniscus as well.
So what would you do here? Professor Schöttler from Munich phones you and says, "This is a kite. This is my friend. Please treat him appropriately."
22-year-old. On the stress views, it looks like there's about 10 millimeter.
Professional kiteboarder.
Treat him non-operatively unless there's, I don't see any other ligamentous injury. Eh?
Yeah, perfect. So he basically has no opening or very mild opening that's less than 3 millimeters. And our indications for open, and this is an effort-based review, which is, I think, is always nice to fall back on because it's such a controversial topic. At least you're not falling out of line. The indications for non-operative management is basically grade 1s and 2s. That means you don't want to have valgus opening in 0 degrees, which we don't. And we don't want to have more than 3 millimeters side-to-side difference, because then it becomes a grade 3 injury on stress views. The management is a hinged knee brace, and usually, depending on whether it's a grade 1 or 2, you go by the pain that the patient experiences, and once that pain is gone, they can go back to sports. But usually what happens in a grade 2 injury, that minimum they need to be off sports for 2 weeks. But for me, I usually just tell them 6 weeks. 6 weeks is kind of like the norm, where you use a brace for 6 weeks at least, day and night, and ideally another brace for another 6 weeks, only during the day. So that's the safest way to treat these injuries. But in the professional sportsmen, they obviously have a different kind of approach, management team around them, where it's quicker. Okay, Benjamin, this is a 22-year-old Springbok rugby player, and she's got this femoral-sided grade 3 MCL tear, you can see here. And she's got valgus instability in 0 degrees. What do you do? Benjamin, are you maybe not listening, or you? Let's see who else is writing. Bayanda. Yeah, you guys are all just that monotonous voice. That monotonous voice is just putting.
Can you hear me?
Yes, I can hear you well. What would you do here? She's a 22-year-old Springbok rugby player. I've given it away. Yeah.
So how acute is the injury? She's going to need operative management, Prof. It's a grade 3 MCL injury, and you gave it away because you already took her to theater and did an arthroscopic repair. But let me just, for my sake, describe the images that are in front of me. This is a T2 weighted image. It's a coronal cut. The ACL is intact. There's a signal on the femoral side. Looks like it's on the medial femoral side of the knee. The meniscus doesn't seem to be detached from what I can see, but there's a little bit of fluid at the bottom, or signal right at the bottom in the corner. So perfect. I'm not sure.
So that's perfect. So she's got this grade 3 injury, and now it doesn't necessarily tell you that she needs surgery or not. It's just an indicator that there's fluid in the tissue there, blood. But you need to assess her clinically and see if she's got valgus instability in 0 degrees, and then make the call. And you can also see beautifully the deep MCL is torn, as well as the superficial MCL. They're both torn off the attachment sites. So I just want to show you this. You see, so this is actually the deep MCL, and you can see that the meniscus is lying on the tibial plateau, and but you can see quite nicely proximally to that meniscus. And so these are 2 sutures that I place arthroscopically, so I know where I am, and then I move to the outside of the knee, and I put those sutures. I basically whip stitch this meniscus into the epicondyle, on the outside. This is a controversial case, so I just because I have you here, let's see who else is right. So who else is writing? Mohammed? Daoub?
Yes, Prof.
What do you think? Yes. This guy is a 50-year-old, very active guy that wants to ski next season again.
Okay, Prof. So I'm presenting this guy. He's 50 years and he's got a grade 3 MCL as well as an ACL tear. So looking, I want to comment on an MRI. There's 2 views. There's a coronal and a sagittal views of the T2. And what I can see obviously here, So there is an MCL. There's more in the femoral side, and it looks like both the deep and the superficial MCL. I can't see any meniscus injury on the medial side, moving towards the notch. So there is some discontinuity, but I think, I'm not sure, Prof, if he does have a complete fracture of both bundles of the ACL or not.
Okay, so let's just assume he has, because I've assessed him clinically and this ligament is torn.
Okay.
So what would you do? 50 years old.
50 is very active. To be honest, I will push towards the operation. We'll do the reconstruction of his ACL and MCL, and because that, if you leave it like that, so basic patients will potentially have further damage, osteochondral damage, and then meniscus tear as well.
But he might heal. His MCL might heal, and if he says to you, "Hey, you know what? I'm done skiing."
Yeah, it does. It might heal, but he does have an ACL.
He's 50. I mean, Prof Roche, how old is he now? Maybe a bit older. Prof Roche doesn't have an ACL and an MCL. Nick Kruger doesn't have an MCL. Well, he doesn't have an ACL, sorry. Brendan Dower did almost like 5 to 10 years without an MCL repair.
Yeah, so my concern is not about MCL. MCL can potentially heal if you immobilize them. Like if you do the ACL reconstruction put a patient in the wrong brace. I think my concern in the ACL, so I would choose the ACL reconstruction with conservative treatment of MCL. But again, it's a controversial.
What's the problem with that, Mohammed? What if you you do a reconstruction of the ACL and you just put them in a brace and you treat the MCL conservatively?
You will have a high potential failure rate of the ACL, of the graft. Yeah.
Exactly. So the danger of this is that your MCL won't heal, and then the patient will stretch out his ACL graft. And the ACL needs the MCL to protect it from rotational, instability. So basically, what I'm trying to say, and I've put you in a spot here, but you've answered everything correctly. The main thing is really it's controversial, and you have to discuss this with the patient. These are the 3 options, and you have to just kind of find what the best option is for the patient and for your setting. So you can treat it both conservatively and see if the MCL heals. If it doesn't heal, then you need to tell the patient that most likely he'll need a MCL and ACL reconstruction, whereas now you could have just repaired it. If you say, let me do the ACL reconstruction now, and it will just put you in a brace, then you might run into trouble when the MCL doesn't heal. And if you do both, you reconstruct the ACL and you repair the MCL, you might run into stiffness of the knee, and it's really a big problem with MCL repairs. Okay, so that's all I wanted to kind of tell you about that. So the main indication.
What did you do for him, Prof?
I chatted to him about everything, and he just wanted to have everything done surgically because he wanted to get back. He already booked his next skiing trip in December, so he decided for that. But this helps you also. So the main thing, so in the end, when you really consider surgery, is when you have a grade 3 injury of the ligament with valgus malalignment. So if you take a long leg view or you look at the knee and it's in valgus and you have a grade 3 injury, there's usually no controversy around this, that they should have surgery, because it's a massive undertaking if it does become a chronic injury. So this is what Sama was asking. Also in multiligament knee injuries, the trend goes to surgery. For tibial-sided injuries, because they don't really heal as well, because the bone is quite hard around the tibia. For bony avulsions, because they actually heal much quicker and easier than doing a delayed reconstruction if they heal with an elongated ligament, and if the MCL is entrapped in the joint. So I don't want to bore you with these slides. The main thing is really just to find the exact points of fixation of the ligament that you want, the part of the ligament that you want to repair. And then there's, like John has said, there's also now more and more people are starting to augment this with fiber tape. But again, if this fiber tape is not in the correct spot, you're going to have a loose knee that's stiff. So this is a tibial-sided MCL tear, and you can see it's quite broad. The tear is quite broad. So if I just take one spot and I put an anchor in there, I will not fix the function. I will not recreate the function of the posterior part of the ligament. Whereas if I put one in the back, I don't recreate the anterior part of the ligament. So, you know, I've put two anchors here, one for the front of the tibial insertion and one of the back of the tibial insertion, and then you can see the internal brace is there just to give it some extra stability. Yeah, I've got another one. This is a tibial-sided tear. This is yeah. This is what I wanted to show you. Soccer players have, and we have one in the clinic, and we might operate on her on Thursday, Delroy. She is a Western Province soccer player that has had a tackle, and she tore her deep MCL. Her superficial MCL is intact, but she tore her deep MCL. And in these soccer players, when you have valgus, you put valgus stress on a knee, there is no difference in side to side in your valgus stress. So they don't have MCL instability in terms of valgus, but they have rotational instability and a lot of pain. So in isolated deep MCL injury, this is a new entity that people are looking at to repair in patients that have got resisted external rotation pain. So when a soccer player wants to shoot the ball with the inside of the foot, and she describes that, and Roy, I want you to ask her, when she hits the ball with the inside of the foot, she's got lots of pain. When she hits it with the laces, she doesn't have pain. So that's always a very a good sign to think about, or to direct it to these deep MCL injuries. The reconstruction of the posterior oblique ligament and the MCL is another kind of thing that people talk about quite a lot. You basically try to find the two central points of the attachment sites of both ligaments, and you either take two different limbs, or you take a V-shaped limb and you just fix it onto one tunnel in the epicondyle. But then you're not completely isometric for the PCL. You need to tension it, like we said, the posterior structures in 0 degrees and the anterior structures for the MCL in 30 degrees. And then this is the last slide. The physiotherapy is quite important. If you discharge a patient and see them in 6 weeks, they're going to become stiff. They need early range of motion. You need to restrict it to 90 degrees, but then after 2 weeks, they need to increase the range of motion. They need to be non-weight bearing for 6 weeks in these grade 3 injuries, and then brace it for at least 3 months. Anyway, this is a very detailed protocol that Laprade wrote, and it's always nice to kind of have that and give it to the patient. That's what the MCL looks like, and I've wasted a lot of time as well on it. It's just so dear to my heart that I couldn't stop. Is there any questions? No questions, guys. Okay.
So with that deep.
Yeah. Ask. Delroy, you've spoken, but Kim, let me ask. You go first.
Those patients, just out of curiosity, those patients that presented with stiffness, and that you this incorrectly, did you ever go back?
You know what, Kim, why don't you send me this with a message, and then I'll answer Delroy's question, because I couldn't hear you properly. Delroy, you?
Yeah, I just was going to ask about that football player with regards to repair. So you just reef it up and then put in a whip stitch and then attach it to whatever tibial or femoral sided.
Yeah.
Because that going to take the pain away just by tightening the ligament.
Yes. So hopefully now, besides reefing it up, we obviously also going to try to create some bleeding, some healthy bleeding, and make sure that it heals. It gets stuck onto bone somewhere.
Yeah.
But it's a chronic ligament that should be reconstructed. You're right. You know, so with an intact superficial MCL, now to be able to reconstruct the deep MCL, we'd have to take the superficial MCL down to do that. So, you know, you're like kind of a little bit stuck.
Yeah.
It's exactly the conundrum that you have with these deep MCL injuries, isolated deep MCL injuries.
Yeah.
Any other questions? No. Okay. I think we've got time for a quick. So you wanted to have ACL?
ACL, please.
ACL. Okay. I've had all the other ligaments open except the ACL. Okay, let me see. So I'll do anatomy, then I'll do ACL evaluation, and then after that I'll do treatment of ACL injuries. See PCL. There. Okay, you can see this.
Yes, bro.
Yeah, this guy, you know, the Körperwelten, this guy has kind of done this first in Heidelberg where I studied. So there's like this special anatomy. He's a weird guy, but he's got this special interest in these, in anatomy. And so a lot of the anatomy of the ACL that I know has been also done by his team that supervised one of the knee surgeons that I worked with in Heidelberg. So basically, what it comes down to, Freddie Fu, who died this year from Pittsburgh, came up with this concept that there's actually, the ACL is not just a round ligament, but it actually has two bundles. It's got collagen, which is very strong tensile strength. It's got basically 90% type 1 collagen, and then it's got just at the notch fibrocartilage bony attachments, fibrocartilage collagen of cartilage where it kind of hits the notch, which might have to do with positional, a sense of position during range of motion. And it's got some pain fibers. The proximal parts of where it inserts in the bone is quite cellular, and as you move into the middle part, those cells become less and they become fusiform spindle shape. So it basically means that the further you go into the middle part of the ACL, the less cells you have, and the more lazy those cells become. And then distally, it becomes, they turn into fibroblasts. And your density of collagen becomes lower. The arterial supply is usually a little bit through the fat pad that we take off when we do surgery, and quite a lot through the middle genicular artery in the back of the knee that kind of feeds off the popliteal artery. And you can also see that there's a little bit of a watershed area here in the middle part of the ACL. And so Del Roy is going to speak to us, or if he wants to, still speak to us about the ACL repair later on, and that becomes quite important then. So this is a nice view of the first guy, the slide of the first guy that kind of came up with this whole, that realized that the ACL wasn't really perfused that well in the middle part of it. Yeah, so fat pad, we got this avascular zone. It's innervated. It's got some fibers, and those fibers basically tell you the kind of the stretch and the positional, give you positional feedback, but also give you pain when you tear it. when people look at the ACL, depending on how you look at it, you can describe it however you want, however the eye of the beholder sees it. So people have described it as 3 functional bundles: the antemedial, the posterolateral, and the intermediate. And later on, I'll show you another nice study of anatomy that actually describes it completely differently, but both of them are somehow right. So the antemedial bundle inserts anterior and medial on the tibial footprint. That's why it's called anterior medial bundle. And it then courses deep and low. So when you have the scope portal in and you look at it with the camera, you describe it as deep and low. Whereas the posterolateral bundle inserts posterolateral on the tibial footprint, quite close to the lateral footprint of the lateral meniscus, the anterior horn of the lateral meniscus. And then it then courses shallow and high in the femoral footprint. And obviously, if you wanted to just kind of repair both bundles, or maybe if one of the bundles only is torn and you want to repair the other one, you kind of have to find those anatomic relationships again. The main thing is really that in the mid-flexion, the anteromedial bundle, in mid-flexion, the anteromedial bundle is the one that's tightest. In the extended knee, the posterolateral bundle gives you a little bit more stability. So the posterolateral bundle is slack in flexion and tight in extension, and the anteromedial bundle is slack in extension and it's tight in flexion. And that's why if you want to err anywhere in that footprint, that is oval-shaped footprint here on the femoral side, you actually want to err towards the anteromedial bundle, because that's where most of the ACLs tear in flexion or mid-flexion, and that's also where you want to have greater stability. That's also where we test at 30 degrees and 90 degrees. So you want that bundle. If you want to err somewhere, you want to make sure that your tunnel comes closer to this bundle. So midline or closer to the AM bundle, both on the tibia as well as on the femoral side. This again are those tensioning patterns of both bundles. You can see that in flexion, the anteromedial bundle lengthens a lot more than the posterolateral bundle. And they've done quite a lot of cadaver studies to kind of figure that out. So when you look at the scope, with the scope from the medial portal onto the knee, you can see distinct anatomic landmarks that you can really only see if you take away all the soft tissue. You can see these bony ridges. And the main ridge is dividing giving you the kind of posterior condyles. This is this ridge. And within the ridge, you have a smaller ridge that allows you to distinguish posterolateral from anteromedial bundle. And this is called the registrar's ridge. And so oftentimes when you look at it from the lateral side, here you see it from the medial side, it's so nice to see. But if you look at it from the lateral side, you have to look around the femoral condyle. You sometimes don't see that this is actually, you think that this is the back of the condyle. And so you really have to define this posterior part of the condyle to be able to see where you are. The other option is to leave a little bit of the footprint of the ACL there, so you can see it exactly, and you can put your tunnel there where on that oval footprint exactly where you want it. Here's another dissection of kind of where this relationship, what the relationship looks like of these bundles. So in essence, the intracondylar ridge is this ridge that shows you the posterior that divides the posterior from the rest of the condyle. And it's not easy to kind of see the long axis of the leg when you scope, but it has this kind of flexed relationship to that axis. And then the bifurcate ridge or the registrar's ridge is basically where the AM and the PL bundle are split. So this is the anatomy of the footprint, and you can see these ridges in half of the knee. So it's not that common to see, especially if you don't really, we don't really look for it. So a lot of this literature comes out from the double bundle surgeons, and they moved away from that because they realized that the double bundle doesn't really have that much more benefit in terms of retear rates or patient outcomes. So biomechanically, it's a better construct, but it didn't translate into clinical improve clinical outcomes. Now, what's quite important on the tibial footprint is that the PL bundle and the AM bundle are in close relationship to the lateral meniscus. And you want to make sure that you don't put, when you start to reconstruct it, that you don't put your tunnel in the footprint of the meniscus and damage it. So you basically want to feel the medial epicondyl, the medial eminence, and then walk the AMA towards the midline. And then you can orientate yourself on the posterior edge of the anterior horn of the lateral meniscus, and that is basically the midline of the footprint. So in some patients, you don't actually see a stump anymore, and it's really difficult to orientate. So that's basically what you use it as orientation. So you can place it in the middle if you are just in line, or maybe just a little bit anterior if you want to err towards the anteromedial bundle. And here we see kind of the anatomic footprint again of the tibia. You know, here is the meniscus, and the meniscus is actually almost like underneath. Here, medial meniscus, lateral meniscus. So the meniscus courses underneath the ACL. The ACL is almost like this the ribbon-like structure that is attached around the meniscus. So if you place your footprint, your tunnel here, you damage the meniscus. If you place it here, you only damage parts of it, but you still, you know, damage it. So there's again that relationship. You can see that the footprint of the meniscus is basically right underneath the MCL, the ACL, and that's the main thing that you need to understand in terms of the anatomy of the ACL. This is a new thing that didn't come out. I mean, it's quite old already, but the concept is basically that the ACL is actually a ribbon. And because you take a ribbon and if you take a ribbon and you twist the ribbon around itself, it can look like a bundle. So the footprint is actually on the femoral tunnel. These authors say that the footprint is actually almost like a very flat, elongated footprint. And like you see here on the tibia, it's the same. It's a very elongated flat footprint. And obviously, because we're surgeons, we have tunnels and we need to place bundles. Then we say, okay, well, there's two bundles. But actually, because we can't really yet reconstruct a ribbon, and that's why, you know, we kind of come to these anatomic bundle, the philosophy of having bundles instead of just a ribbon. Have you guys got a question on that? No question. I wonder how many of you are still listening.
Prof, I've got a question.
Yeah?
You say to delineate that anatomy, it's quite nice to clear up that femoral condyle so that you can really see where you are.
If you're looking for the ridges, yes, but if you're looking for the stump, then it's almost the opposite. Then you're taking away
exactly. Yeah, and then the other thing is you obviously lose some of that proprioception you get from your stump. What's your feeling about maintaining that stump for proprioception?
Yeah, it's also, you know, a lot of it is fashion, and there's good sides and bad sides to leaving a stump. For example, if you leave a stump, you have proprioception, you don't have extravasation of joint fluid into the tunnel, and then potentially cyst formation. There's downsides of leaving a stump is that you don't actually know exactly where you are on the bone, and that you potentially have too much tissue there. And with the ligament reconstruction and the stump, you might you create too much tissue in the notch, and you get notching or impingement or a cyclops lesion. So I like the stump to be there, but then if I have a big stump, I just have to adjust or consider the thickness of my graft at the end a little bit more. And if the stump is attached to the femur, it becomes very difficult to really see where you are, and to also measure your tunnel lengths, and because you don't see where it goes through, where the guide pin goes through, and you can't read off it. Oftentimes you spin with the drill, and the drill spins, and it spins the stump in that you've tried to preserve for the last half an hour, and it just becomes this big mess of tissue. On the other hand, if it does go well, it's beautiful because you can put your ligament straight into the stump, and the patient will probably feel like he never had an ACL tear. I'm going to go on. If I answered your question. Okay.
Yes, thanks very much, Prof.
Cool. The evaluation of ACL injuries. Such a big thing because you can't, it's sometimes so subtle when when you sit in front of the patient, you do the Lachman test, and you jump back from right to left and left to right again, and you really like struggle, and you're thinking, fuck, what, especially if you don't have an MRI scan, not easy. So try to use as much information as you can from the other things that you can assess. So ask the important questions in history. Did your knee swell up immediately? That means basically, did you have a big ligament tear or fracture in the knee that gave you immediate hemarthrosis, which ACL does compared to meniscus tear? And then also, ask about instability, subjective instability. And then there's a couple of clinical tests I'll show you, what you can look for in X-ray and MRI scan. So this is Michael Owen. You can see a lot of ACL tears happen in non-contact injuries. It's a rotational force where the tibia internal rotates.
Your slides are not showing.
Say that again.
Your slides are not showing.
Oh, shame. Sorry, man. Thanks that you mentioned this. Fuck, I would have share slides. Okay, no. Basically, you can see that usually the body external or rotates over the knee, and the knee basically internal rotates, and that's where you get this. You tear the anterolateral capsule, you tear the ACL, and then you hit the lateral femoral condyle on the posterior medial rim of the tibia. So that's why we, with this is actually a tough video to watch, but it's such a nice video to see and to correlate the injuries that you see on MRI scan with the movement of that leg. So various ways to specific tests to confirm ACL tear. The drawer test, the Lachman test, drawer 90 degrees, Lachman in 30 degrees. It's got a lot more. It's a lot more specific than a 90-degree drawer test because it cancels out other ligaments that are in midflexion are a bit more lax. The Lilly or lever sign. And then we've got some pivot shift and rotational laxity that we need to assess. So these are the specific tests. If you get an exam and they ask you, here's someone with a ligament injury of the knee, and you say, okay, well, most likely an ACL tear. Let me check. Oh, he's got an ACL tear. There's things that you can talk about that are more than just the Lachman. So the pivot shift is something that you don't really do with the patient awake, and you can grade that, and you can kind of confirm how much rotational laxity in that shift lies. We're still trying to figure out what makes a pivot shift pivot, which structures are torn in a high grade compared to a low grade pivot shift. And we're also trying to grade it still because no one, can objectively grade it yet properly without, other means. And then rotational laxity, I'll show you as well. These are things that you need to exclude. PCL injuries, very important. Meniscal cartilage damage. There's a lot of association between those structures and ACL injuries. And you sometimes get delayed a solid endpoint in delay presentations because the ACL actually adheres to the PCL and gives you this false feedback. So you just need to be aware of that. So the other thing is, if you miss a PCL injuries, or if you miss an MCL or LCL injury, rotational laxity, then you can have the perfect ACL reconstruction with perfect tunnels, and in a couple of years that patient comes back to you with a failed test. Ah, shame. This doesn't work, but this was my pivot shift. The pivot shift is basically a test that you do in valgus, internal rotation, and extension. That's how you start, because you want the tibia to be subluxed anteriorly already. And then as you move the knee into flexion, the ITB becomes an extension moment. From an extension moment, it turns into a flexion moment, and it pulls the tibia posterior. So this is the best way to describe a pivot shift to an examiner, and also just to do it. The stuff we look at on x-rays are the slope. We look at smaller avulsions, like John has said, and we want to look at the varus, because varus and the slope actually affect they do affect how you look at how well your ACL will do, and if you potentially will have early failure of your ACL tear. The deeper the slope, so the more slope you have in the tibia, the more the tibia wants to translate anteriorly, and the more the femoral condyle wants to move backwards. So that means you put your ACL on a lot of stress, or your graft on a lot of stress with an increased slope. So what are direct signs and indirect signs on MRI scan? Why do you have an MRI scan first? Well, the MRI scan confirms the diagnosis. It lets you talk to the patient about the associated injuries and kind of discuss these injuries, and it gives you some feedback in terms of how urgent this is. You know, is there a lot of cartilage damage already? Is this knee? Is there a bucket hand meniscus that needs to be reduced? Or can it wait in someone that's 50, 60 years old and doesn't have any major cartilage damage? We'll get to the indications with surgery, but on the MRI scan, the problem is that the ligament is an oblique ligament, but the sagittal cuts are made basically orthograde sagittally. So the ligament is never, compared to the PCL, the ligament is never sliced through its entirety. And that gives you a false sense of the ligament structure. So the PCL is always nice, and it's got a high signal, but a low signal, but the ACL will have high signal within its fibers because they're orientated obliquely to the cut. So it's sometimes difficult to really figure out whether the ACL is torn or not. So a good way to look at this is to look at indirect signs. And an indirect signs is basically if the ACL fibers are not orientated according to the Blumensaatz line. So if they fall down more than 45 degrees to the horizontal, that's usually an ACL tear. You can look at the empty notch. So if you don't have it, that's basically an empty notch sign right there on the coronal. You can look on the coronal also at the discontinuity of fibers. But one of the best ways to really confirm that there's been some serious translation in the tibia is to see these bone bruising, the bone bruise in the femoral condyle. Like I say, the lateral femoral condyle hits the medial tibial plateau as it basically moves back, and it creates these big areas of signal. You can see, and also on MRI scan and X-ray, see Segon fractures that we know point towards an ACL injury. And you can also have a look at the PCL. If the PCL is not if this PCL here is not a nice round shape, this is unfortunately not the correct slide to look at the PCL. But if the PCL is buckled, like my finger now, you know, if I put my finger over another finger, it's a nice round shape. But if I don't have another finger on top of the finger, then it becomes buckled, and you can look at that. And then, yeah, some people look at the anterior translation of the tibia and uncovered posterior horn of the lateral meniscus. It's not easy. It's not easy to see this because the patient might be reduced while he was laying down for an MRI scan and not translated anteriorly. So these are subtle signs. So the entirety of these signs basically give you good indication. But in all, it is a very good way, 90% accuracy for meniscus tears and almost 100% accuracy for ACL tears. And that's why we do it. It's almost like the HB for us. This is a nice meta-analysis where we basically see that this is a rock curve. That just means the further up in this corner, in this left upper corner it is, the more sensitive and specific it is. So most of the studies found that it is sensitive, quite sensitive and specific, the MRI scan. So it's the gold standard to detect this injury. Not sure what I wanted to say here. Yeah, don't be fooled. If you look at the, say arthroscopy is the gold standard, it's sometimes quite tricky to really see an ACL tear, and especially if the ACL is partially torn, or if it's attached to the PCL, or it's maybe even just stretched, and actually you're looking at the PCL injury and the ACL is intact, and it gives you a false sense of a lax ACL if the tibia is translated posteriorly. And so I think I would definitely would move away from using arthroscopy for diagnostic purposes. It's good to confirm your diagnosis and to make sure that you're not missing anything on MRI scan, and to define the injuries better, but you shouldn't. I think I would move away from just doing ACL surgery if I have an MRI scan available. Obviously, if you don't have, then it's a different story. So yeah, people are saying diagnostic scopes is like a washout, a wallet washout. So the main thing is really ask for the classic story in your exam. Figure out, is this just an ACL tear? Are other ligaments involved? Is the joint tendinous that points towards a meniscal tear? What are the rotational problems that you can kind of figure out? And here it's difficult to do a pivot shift, but before you start your surgery, a pivot shift will really help you to see whether there's huge rotational problems in the knee, and an MRI scan. Are there any questions?
Prof, can I ask one quick question about ACL?
Yeah.
So I remember there being the sort of concept coming up about ACL reconstruction in a slightly older age group. So yeah. I suppose the first question, based on older patients now, I mean, I'm saying sort of 50s, 60s being more and more active these days, and then also the combination of ACL reconstruction being protective of degeneration of a joint. Obviously, in our setting now, being resource limited, we don't really have this option. But if resources weren't much of a problem, is there any sort of leaning towards more reconstruction in that older age group?
So one thing is, and that's not completely understood, is whether ACL surgery does give you, protects you from osteoarthritis. And there's a recent BJJ article out on that, and it's in the recent BJJ issue about that. So, and we don't know why, but often ACL or osteoarthritis and ACL surgery have been associated with each other. Whether the patient has got more sports or hours left after ACL surgery, we don't know, but it certainly helps the younger patient to avoid meniscal damage. And because what happens when you don't have an ACL anymore, the other structures of your knee have to take over the restraint against anterior translation. So most of the time, that is the posterior part of the medial meniscus, because it's attached to the capsule, and the medial meniscus basically holds and cups the femoral condyle. So once the tibia moves forward, every time it moves forward, the medial meniscus takes some of that strain from the ACL. Now that's only if there's no more anterolateral ligament and no more ACL. So that's why also, the chronic tears usually give you, or in the chronic instabilities, you usually get MCL tears, a medial meniscus tears with it. Now, with the older patients, and in any patient, it's always a conversation about three things. The one is your age. The other one is how unstable you are. So how much translation can I elicit, and how much translation do you feel during your day-to-day? And the third thing is, how active are you? And there's scores you can take and scores that can guide you with these three components, but it's always a conversation with the patient. So you always kind of just have to tell them, about the risks and benefits, and then kind of take it from there. And like I say, our consultants is a perfect example. Even people in your registrar group, they decided, hey, I don't need an ACL. And eventually it comes to a point where they're like, you know what? I'm still so young and my knee is pretty much completely damaged now. Let me rather sort it out. Or Nick Kruger, I need to go kiting. I need to go surfing. I need to go water polo, do water polo, and my knee doesn't give me the activity that I want. So I want an ACL reconstruction. The only guy that's still missing is Steve Roche. He just bites his tongue and just, or his teeth, and just goes and does his marathons and then has a swollen knee for 2 weeks. Am I recording this? Yeah. Okay, did I answer your question?
Okay. Yeah, pretty much. Thanks.
Guys, we are like running massively over. I think we must just do the ACL. And I hope I'm not talking too much shit in between, or like when I present. I could obviously rush through all these things, but I think it's nicer to just have like I say, this ACL part is actually an entire TUT on its own. And I might just have to do the rest of the ligaments in the next TUT that I'm doing. Let's do that, then we don't have to. But let me finish the ACL. Is that okay?
Yes, that's fine, Prof. Okay,
cool. So we've spoken about the anatomy, we've spoken about the assessment, and also now a little bit about the indications. Now let's speak about the technique of doing an ACL reconstruction. And then I would like to just have 5 minutes for Delroy. And I don't know if Mohammed, if you prepared anything for you also, just a couple of words on repair of ACL reconstructions and how the slope affects ACL reconstruction. Surgical technique, here you go. Share screen. Okay, this is the GSH technique. If you go to Europe or to the States, you'll find a completely different technique. So this is just something that works for us here, but I'm not saying this is the only way to do it. There's so many different companies that provide instruments and implants for the surgery, and there's such a huge pressure on the clinicians in terms of the industry, that there's a huge variety, and also all these kind of fashion items and procedures that pop up every once in a while. But this is kind of like the trial and tested technique in our hospital. So when the setup, what I like at the setup is, you see here, I like the toes. When you put the toes on the knee, it gives you like a 90 degree bend in the knee. And then the heel, it gives you a 70 degree bend. That's basically, if I work on the femur, I go to 90 degrees. If I work on the tibia, I go to 70 degrees. In 90 degrees, the fat pad is pushed towards the notch, and you can't really see as nicely as in 70 degrees. But in 70 degrees, you can't actually get into the back of the knee on the femoral side to really understand where your femoral tunnel needs to lie. And I kind of mark, or just kind of look at where I want to be on the femur, where the tunnel should come out, or the pin for the tunnel should come out. You can mark, so Delroy, on Thursday, you're going to have to mark this perfectly. So the kneecap, then you need to mark your tibial, the patellar tendon, your tibial tubercle. You want to mark your joint line, and then you want to put the lateral a little bit higher and closer to the tendon than the medial. That just gives you, and again, it's our way. It's not everybody that does it like this, but it just gives you a little bit more play with your instruments. So this is the accessory medial portal that I like, because it helps you to drill nicely the femoral tunnel, and the anteromedial portal helps you, if you want to see where you drill the tunnel. So you can put your camera in here and you can drill through this tunnel. So this is what you see from lateral, and then you run risk of seeing just the registrar's ridge, and you think, okay, I'm going to put my my tunnel in here, and this is what you see from the medial portal, where you can see a lot better what the entire shape of the corner looks like, and you can really place your tunnel where you want it to be, depending on what your philosophy is. In terms of the grafts and where you want to position where you want to harvest them, is initially just make a bigger incision, so you really see where the hamstrings attach and where they go, and it's basically in line with the tibial tubercle is where the top of this graft usually starts, the hamstring graft. So if you look at hamstring, there's different ways to set it up. Nice thing is to move the leg into abduction, so the hamstring tendons comes out from underneath the tourniquet, because otherwise you're going to really struggle to pull that hamstring tendon out. You start with a routine arthroscopic exam, and then you release the ligamentum mucosum, and you ideally just provide enough fat pad to see the anatomy perfectly. You want to see that kind of, this is the lateral femoral condyle, and you can see that there's no tissue here. That is an ACL tear. The old ACL, can be stuck on the PCL, and it makes you look like the ACL is intact. Drilling the femoral tunnel there's a lot of kind of techniques around that. We use the AMA, but the best way to really drill your femoral tunnel is to look at the femoral condyle through an anteromedial portal, and through an accessory medial portal, drill exactly where you want to be. Because if you use the AMA, you're using it mainly by looking from lateral, and you just feel with the AMA where you are, but you don't really know exactly unless you move around to the anteromedial portal. And then you've got this femoral tunnel, and like we said, the femoral tunnel. Now, if you drill it anterior, you're in the wrong place. So try to make it as much deep and low as possible. The other thing is also, by changing the alignment or the orientation of the beath pin, you're able to make it longer if you come more to the midline, or you make it shorter if you basically try to drill it right through the femoral condyle. And the problem with shorter tunnels is that the cortex is less. The cortex is a bit less stable and hard, and especially in a patient that's got very soft bone, you can actually pull the endocardium through the bone there. So that's a nice low, deep tunnel. This is a tunnel that's too shallow and too high. Then the tibial tunnel placement I've chatted to you about. We're not going to go through that again, but these are kind of like the orientation lines that we kind of teach and look at. And in the graft, is basically when someone asks you, hey, what graft are you using? You should say that this is what you've been taught and this is the graft that you use, but you should understand what the other grafts can do and why they're used. In other hands, they might be much more favorable to use. So the hamstring graft is a good graft. It's got low donor side mobility. The problem is really that patients don't really like to extend the knee after hamstring harvest, and it can give you fixed flexion deformities if you don't get the knee straight after the first 3 to 6 weeks. It's less pain. It's quite consistent in terms of the tensioning, But the problem is it's a little bit less stiff than the quadriceps and the patella tendon. So that means if you pull it, it has a little bit of play compared to the patella or the quadriceps tendon. It's also not as predictable. So if you really want to have a very predictable graft, you want to use the quadriceps graft because you can cut it. You can cut the quadriceps to a size that you want. And it's not like you pull out the hamstring and say, oh, I've got this graft now. We basically go about 2 fingers from the joint line down distally and 2 fingers from the tibio-tubercle medially, and then you basically look at these tendons that are coming in, and you see that the semimembranosus, is a tendon that you don't want because it's got lots of muscle attached to it. So it's got a short tendon that doesn't really give you a good graft. You want a long tendon that you can fold maybe even 3 times to give you a nice thick graft. And the gracilis tendon and the semitendinosus tendon, they differentiate, or you can differentiate them from each other. Obviously, the gracilis tendon is thinner, but the semitendinosus tendon has got these vinculae that are attached to the bone. So we kind of, and this is where most surgeons have sweated that are starting off, and where I sometimes even I sweat when I can't find it. The best way is always to look a little bit more proximal than you think, and to look on the side of the piece, not on the side of the MCL. I mean, I've harvested MCL, I've harvested tendons that I have, gastrocnemius tendons, and I mean, I've harvested a lot of stuff on that side. And so it's just good, when you don't know where you are, make the incision a little bit bigger, take down the piece even and fold it, and then you'll find the piece, the tendons on the piece. And then what we do is we kind of just rib stitch it and then pull it out. There's various ways to create thickness or girth. So you can do a 4-strand graft, which is this one. 4-strand graft usually gives you a lot more tensile strength than the original or the native ACL. So this graft will not tear when you compare it to the native ACL. But usually you want to have an 8mm, 9mm graft in a male, and at least a 7 or an 8mm graft in a female. So what you can do is you can do a 3-strand graft if you just want to harvest one limb or one graft, or you can do a 5-strand graft or even a 6-strand graft to give yourself a little bit more width or diameter. The question is really, who does this for you? And if you don't trust the person that does it for you, rather do it yourself, or at least check exactly what this person has done. If the whip stitch is poor, you're going to pull and tension it, and you're going to tear out the whip stitch. That means you have to open up on the femoral side, cut off the endo button that's gone through, and then take it out completely and re-suture it. So it's a huge mission. Like we said, it's got double the load to failure than the native ACL. And these are your other options: bone patella bone, nice bone-to-bone fixation, integrates quickly, is a lot more a lot quicker to integrate, and doesn't fail as quickly on the sites of fixation as the ACL, as the hamstring tendon. It is a lot stiffer than the hamstring tendon, and that gives you the feedback of a lot more of a stable knee, and also to the patient. The problem is you're cutting out a piece of patella tendon, you get potentially shortening and patella bia, which gives you anterior knee pain or risk of anterior knee pain, and you have problems of potential tendon rupture or patella fracture. I'm not going to go through this. I think this kind of shows you a nice ACL. You want to have a ACL that's quite horizontal and low, that resists rotational forces. And this is how the endo button works. You kind of push it out of the small tunnel, you flip it, and then you pull it back, And so you need a little bit of space here, and it's always a little bit of a calculation in terms of how much to drill into the bone here until you can flip this button and then pull it back and on basically try to have a fixation point that's an interfering screw and distally as well. So the tensioning of the graft is important. You want to tension at about 30 degrees. If you tension at 90 degrees and you flex the knee, you over tension the anteromedial bundle. So remember, the anteromedial bundle is tight in extension, in flexion. So if you tighten it, over tighten it in flexion, you try to extend it, then you might over constrain, and some people use these graft tensioners to avoid that. Yeah, so there's another knee saved. Any questions?
Hi, it's Ashley.
Okay.
This is a little bit off topic, but how should I say, in tibial plateau fractures with associated ACL injuries in the form of eminence fractures, with the ACL avulsion. The literature seems to be a little bit unclear about whether to sort of fix the plateau and let it, how shall I say, gum up, or to fix the plateau and, fix the ACL at the same time. What's your feeling, essentially?
Ashley, if you have the skill and the theater time, and after like a difficult plateau, because usually those plateaus that have got the ACL avulsion fracture is usually the Shaska 5 and Shaska 6. If you have the guts to put a scope into that knee and deal with extravasation of fluid, if you have the patience after like 2 or 3 hours of surgery to still fix an ACL, if you manage to pull the tunnel that you need for ACL fixation that through all the screws that you've got in the tibial plateau, then you're really a good surgeon. And I'm not that surgeon yet. So in my mind, plus a lot of tibial plateau fractures get fixed by trauma surgeons, and the knee surgeons are a lot more, their lifestyle is so much better than the trauma surgeon's lifestyle. So they don't want to come out at times when the trauma surgeons are doing those surgeries. So all of these things in our setting are probably leading to addressing isolated ACL avulsions less often. Saying that, we've done quite a lot of cruciate ligament avulsions, and I think especially in a knee that is a fractured dislocation and not just a tibial plateau fracture, it becomes quite crucial to stabilize the knee's posts, which is the central post is the PCL. So if you have a PCL avulsion fracture in a tibial plateau fracture dislocation, it gives you a lot more stability of the knee, and it allows you to have a post-operative care for the patient that's completely different to someone that has a PCL avulsion that only had a plateau fixed. So I think I would say in fracture dislocations, it's a different animal, and it should be treated differently with a team that kind of can handle all of it. In an isolated ACL avulsion in a tibial plateau fracture, I would say rather to leave it and then to treat it in a staged fashion. I hope that's what you're kind of asking.
Yes, thanks very much. That helps.
We've done this, and we've tried to kind of address it all at once, and it just kind of becomes a bit of a mission at the end for the theater team, for the patient, for the surgeon. Although it's right in your, if it's right in your face, then just tie it down and just tie it over a screw. But if you have to now make a separate incision, and then it becomes too complicated. Anyone else?
Prof, can I ask you a question, please?
Yeah.
just in regards to multiligament knee injury, in terms of fixation, like in orders, which one you first you start fixing first? Like I know that PCL is first, but then there's some controversy. Which one is it? Posterolateral corner second, or you do the ACL second? And in terms of tensioning as well, so which position you tension them as well?
So in a multiligament knee, and you have the time and the means to do all of it at once. I like starting with the PCL, and then after that I do the ACL, and after that I do the cruciate ligaments. And in all of it, you must just realize the PCL you tension in 90 degrees if you do a single bundle PCL, the ACL in 30 degrees, and then usually the collaterals also in 30 degrees. If it's if it's like a three ligament injury. If you don't have the time, and if you say my time, I'm running out, or tourniquet time, or the extravasation of fluid, then I try to focus just to get the PCL done, and I leave the ACL. I don't actually do the ACL, especially in someone that's a kind of a low, a patient that's not a manual labor, or I would say can cope with the ACL deficient knee. I leave the ACL and I do the cruciates and the posterior cruciate and the PCL. But in terms of tensioning, that's the sequence that I do, and the sequence most people do is PCL first in 90 degrees, ACL in 30 degrees, and then I always err towards tensioning for the PCL. So some people worry about over tensioning the PCL and bringing the tibia too far forward, and then all of a sudden you pull it backwards with the ACL. But for me, I'd rather have a good stable posterior ligament than somewhere in the middle, and you've got a grade 1 ACL and a grade 1 PCL laxity after you're done with your reconstruction. So I always err towards making sure that the PCL is properly reduced, and then the collaterals are really the guards, the safeguards, the wingman of the cruciate ligaments. So there must be no wiggle room in them, so that you don't stretch out the cruciate ligaments.
Yeah, thanks.
Anyone else? 2 hours, guys. And we didn't even speak about the PCL and the LCL. But what I'll do is I'll add that to I'll add those ligaments into my second TUT this year. Dalroy, can you very quickly, for 2 minutes, tell us about ACL repairs?
Yeah, I'll try my best.
Wow, your desktop looks crazy.
Yeah.
Looks like someone that needs to write his exams and then clean up a little bit.
That's exactly an exam
desktop.
Yeah, I've got 10 slides here, just quickly. ACL preservation or ACL repair. Just before going to the stats, you have to know that ACL recon is the gold standard, and that anything that's any new innovations should be then compared to the gold standard. So in the 1970s, ACL repair was the most common procedure performed, and it fell out of favor because they had poor midterm results. They used the open technique. They essentially operated on different type of injury tears. They had a cohort of different ages. They also had concomitant injuries like meniscus and PCLs. And at that stage in the 1970s, the rehab was quite archaic. They used to put these oaks in 30 degrees above knee pop for about 3 months, and then brace them as well. So we didn't have the modern day rehab techniques that we have now. And at the same time, in the 1980s, ACL recon showed superior results compared to repair. So in 1991, Sherman produced his landmark paper, and it showed he had 50 patients, and he looked at ACL tear types as well as tissue quality. And at that stage, he recommended ACL repair only for 22-year-olds, people who were injured in skiing, type 1 tears that I'll get into now, patients with good tissue and a low-grade pivot. So we are so in the background, essentially, of this landmark paper, you had this noisy neighbor called ACL Recon, and because it was the gold standard, there was dwindling interest in repair of the ACL. Until this guy showed up. He's a guy from the States. He's got an Italian surname. But yeah, he essentially revived the interest in repair. So currently, our approach to ACL tears is quite dogmatic. So if you're a high-level sports athlete, you'll get an ACL recon. And if you're a weekend warrior, you essentially get treated non-operative most of the time, especially in resource-limited setting. So with ACL repair, you can add another skill to your armamentarium. So while repair the ACL, it preserves the biology. Like Prof mentioned, you maintain your mechanical receptors, you decrease the morbidity of reconstruction, and you don't have bone site or donor site morbidity of the graft. And essentially, you also don't burn your surgical bridges if you need a recon at a later stage. So the indications for ACL repair, so this guy, Greg, developed this algorithm, and he used the paper of Sherman to reclassify ACL tears. So essentially, the most proximal, so your type A and your type B injuries, either bony avulsions or very proximal avulsions, you can treat with repair. And this, and then your tibial, your type E and F, you can also treat with repair. And then the mid-substance tears essentially gets treated either with reconstruction. So you essentially look at what the tear type is and the quality and how much of the substance of the tendon is remaining. And yeah, there's different techniques. You can repair with a silver lock, which I won't get into, and you can repair with augmentation. And then there's this thing called bridge enhanced ACL repair, essentially taking the patient's own blood, and you insert it into the sleeve, and you get into the stump, and you get reconstruction or repair of your ACL. But yeah, that's essentially my 2 minutes.
Cool, perfect. Thanks very much. So basically, in the tissue must be a good tissue, and the patient must be a good host, and then the tear must be favorable. So it must be just literally right off the bone, and then people consider this. Not a lot of people in Cape Town. I think we're still kind of following that old dogma, but obviously we're watching that space and kind of every once in a while thinking about it. Cool, guys. I think it's been a long chat and completely overrun. But yeah, John, thanks very much for initiating it with a nice kind of overview. And I think that was probably the most important talk in terms of multiligament knee injuries. That's really what you're gonna use in your day-to-day practice, the concepts that John spoke about, and also what people are going to ask you in the exam. The rest of the stuff is quite detailed, and if you hit that, if you hit the various reconstruction methods in posterior lateral corner injuries or ACL repair discussions, then you've passed already. Cool, guys.